Good afternoon, everyone. I am showing the top of the hour. Thank you for joining us today. We extend our deepest gratitude for all of you who are in the trenches right now, and we really appreciate your time and participating with us on these calls. We will go through a few administrative items first, and then we will go ahead and get started. Linda, if you can go to the next slide, please. We do record these meetings, so if you're not able to stay on the entire time, it is posted on Confluence, the materials and the recording, and everybody is muted, and you're free to unmute yourself when we open up for questions or comments. You can also use the chat feature, which is excellent because many of you have been on these calls before and are able to help the conversation along via chat while we present. So feel free to use the chat feature anytime and send it to everyone. Next slide, please. If you have already joined the project, thank you for doing so. We are up to over 700 registered members. If you have not done so yet, joining the project as an other interested party or a committed member will put you on our email distribution list, and you will get the most up-to-date information and meeting invitations. And as always, for any Gravity Project information, you can visit the Confluence anytime. Next slide, please. We are honored to thank our project founders and our in-kind support sponsors. You will see that the number is growing, and we are ever so grateful that we have this help and this kind of support from all of you. Next slide, please. And if you're interested in sponsoring, you can email gravityproject@emiadvisors.net, or you can go to Confluence, and there's a big blue button on the landing page that you can click on to express your interest in sponsoring this work. Next slide, please. We have a full agenda today. We will go through our project roadmap and upcoming schedule. You all will be glad to know we've pushed out some dates. And then Sarah and Linda and the housing leads will take you through an overview of our new draft master list for housing coding concepts. And then Lisa will walk you through some FHIR IG updates, so you can all be on top of that and learn how you can participate in Connect-a-thons. And then we will finish up with some homework and next steps. Next slide, please. This is where we are today. It is the 2nd of April, and you will see a few lines down. We have pushed out the data element submission date to May 1st. We realize everyone is scrambling, but it's also important for us to have as many submissions as possible for this domain, because the work we do here will lay the foundation for the work that everyone else does. So we really, really appreciate all the submissions we've gotten to date, and we look forward to any that the rest of you can provide on or before May 1st. It gives you another month, and then we will work to review those data elements through the coming weeks as they come through and are adjudicated. Next slide, please. This is our timeline. You'll see we are officially in Q2 of 2020. Time is moving right along, and we're in the housing domain work. And you'll see that the FHIR IG work is also going on at the same time, and Lisa will provide more details about that further on in the call. Next slide, please. We presented this idea the last time we met, and we have some links in this presentation that will be available. You don't have to try to scramble to write these down. You could take a screen cap if you would like, but we will distribute links in our community email following this meeting. But these are some resources that you can review, people who are looking at SDOH data and pandemics and how we can leverage using social determinants of health to fight these kinds of things that happen. Next slide, please. And if you have any thoughts, you can always email us. We have been getting emails from all of you, and thank you for submitting those. I will hand it off now to Sarah and Linda and our two housing leads, Allison and Rich, at this point, to go through an overview of the draft master list.
Thank you, Lynette. This is Linda. I'm going to kick off this section by just showing you some of our submission summary information. For those of you that have participated in the Food Insecurity Project, this slide will be familiar to you. So we have the 4 submissions that we've received to date. The first one was the one from Sarah and our 2 subject matter experts, and that's the one that we've actually finished reviewing and adjudicating, and that forms the basis of the first master list, which has been published. And a few slides from now, we'll remind you all of how to get to and access the first of our housing insecurity, instability master lists. So from here, you can see for each of the 4 activity areas, screening tools for the submissions that have been reviewed. Here's the disposition. So we added 10 screening tools, which comprised over 53 questions. We've added 2 diagnoses, 1 goal. And if you remember, for those of you who were here last year, we split the interventions into 2 separate sections, one for the interventions that would be coded using SNOMED, and one that would be those that would be using CPT and HCPCS. So we added 27 SNOMED interventions and 3 HCPCS, our CPT interventions for housing. Duplicates, at this point, we don't have duplicates because we have to continue. Once we start reviewing additional submissions, we'll determine if anybody submitted the same data element as previously on the master list. We did find a couple that we didn't add. Those were primarily, if you remember also from last year, in the interventions area, we did not add any of the interventions that combined more than one intervention type. So for interventions like counseling and education, we don't add those because we have counseling and education as 2 distinct, different interventions. And the park ones here are those that were submitted, but they are really more appropriate for the housing quality phase of the project and not for housing instability and homelessness. So this is really, you'll see this updated every meeting as we go through and we adjudicate and process more of the submissions that you've sent. So now I'm going to turn it over to Sarah to continue on with this section.
Thank you. So we're just going to frame again the kinds of information we're looking for. So reminding the community that we're looking at housing collectively over the course of 2 phases, really to just focus our efforts right now on housing instability and homelessness. We, as you will see shortly, have an extensive submission already regarding screening tools because of the comprehensive tools we got before with food insecurity, and a literature search that we did prior to the public calls. We're making headway on assessments and diagnoses. We really do need examples of goals of care and intervention. So if you all were to download the master list as it stands right now in the Confluence, you could see that our areas are slim in here. I'm going to do a reminder regarding interventions. So what we're looking for here are the programs we refer to and educate about, including their definitions, the roles we might refer to, for example, with food insecurity, like community health navigators or nutritionists. What are those rules for housing, homelessness and housing instability? And then any applicable intervention activities and services we might not have thought of. So if you remember, we have our intervention framework that we based all of our food insecurity activities around. It might be that there's an activity that's different with housing that we need to consider, and we would love your submissions there. Then I just want to reiterate that we're looking at housing quality in phase 2 once we complete the housing instability and homelessness work. Next slide, please. So I just wanted to give an update. We had a question on this earlier on the screeners that had already been submitted. So these are the screeners as they stand so far. They include PREPARE, the VA homelessness screening, clinical reminder, the North Carolina comprehensive tool, the Accountable Health Communities tool, the Children's Health Watch Housing Instability Vital Sign, We Care, Health Leads, the Kaiser Permanente Your Current Life Situation Screener, WellRx, and the AAFP Social Needs Screening Tool, or the Everyone tool. Simply because these things are already here, it does not mean we do not want you to submit them again. And please submit the tools that you use, because every repetitive submission is further proof that it's worthy to the community and of value, and we just tally up how many times it's been submitted. Next slide, please. So as it stands right now, we have two very simple diagnoses. Housing instability is one. This is new. And then a code for homelessness, which exists right now in ICD-10. This will be refined over the course of the next couple of weeks as we get submissions from our HMIS HIT collaboration, and the subject matter experts themselves work on submissions. I do want to own that initial one was not from Children's Health Watch. It was just from me importing information from the compendium and our previous work with food insecurity. So it's not as robust as it will become in the future weeks. Next slide, please. Oh yeah, we just wanted to reiterate how you can review the housing instability adjudicated data submissions master list. This is always available on the Confluence. The link is kind of small, but it's about a third down from the opening page. You can download the list and review the concepts. You can also follow links to submitting your own data concepts. And I really want to say very clearly, we are here to help. So if the data submission process on the Excel spreadsheet or on the tool that Lisa has so elegantly refined with her team from MaxMD, if any of that seems complicated, just reach out. You can even just send me an email and I'll be happy to help. We do publish the master list following every community meeting as it's adjudicated by the subject matter expert team. All right, next slide, please. Oh, and then I just preempted myself. So this is the same link you can go to submit data concepts. And again, I'm here to help. I think Rich knows I did a little bit of carpetbagging last time with food insecurity to get the voices of the people that I knew on the ground to submit. And we're trying to do that again here with housing. Again, fully recognizing the bandwidth limitations, given that the COVID crisis is putting a humongous amount of pressure on the housing and homelessness community. And we recognize that very clearly. Next slide, please. Any questions so far on what we've presented? Opening it up to the community, you can pipe in the chat room. It looks like we have, is Lisa on the call yet? Can she answer this question from Ankit?
No, this is Lynette. Lisa is having technical issues and I'm texting her as we speak. We can answer this question, Ankit, here in just a minute. I have a message out to someone else, so we will get the answer to that shortly. And
Lisa is coming to the call shortly, hopefully.
She will be. We're working on it. Thank you for your patience.
Thank you.
Any other questions I can answer? So I again just encourage you all to download the master. I think it's pretty impressive to see us roll in what we've learned from food insecurity already. It's much more robust than our first master was last time around. And we do look forward to having you review it and see what the gaps are, and then try to work with your stakeholders and communities to fill those gaps together. Oh, is there a reason? Oh, this is a different, there's lots of important questions regarding the Connect-a-thon. All right. I guess we can move on then. Next slide, please. So, oh, this is supposed to be Lisa's section though. Oh, Allison, I'm wondering if we were going to talk briefly about, you had some thoughts regarding the differences between food insecurity and housing regarding the program approaches because of the local subtleties as opposed to the federal responses. Allison, do you want to pipe in?
Sure. When Sarah and I were talking about some of the things that came up in terms of resource connection from the food insecurity piece around getting people enrolled in SNAP and WIC and other large federal programs, we were discussing that while this is certainly something that we can replicate on the housing domain, as there are a number of federal housing programs, we also recognize that there are a lot of state and local programs that are very specific to certain areas. And so one of the things that we were talking about is when you have those sorts of program connections, trying to capture the type of program that it is. For example, permanent supportive housing or rapid rehousing, or some states have emergency assistance fund rental assistance funds that can be accessed one time, or other solutions, eviction prevention resources that might be particular to a certain state, that sort of stuff, that those are also welcome and encouraged.
And then what we'll do with Allison's help and the help of the community is then sort them, those possible variants in different programs across different localities, regions, and states and federal government into those parent concepts like we had with food insecurity. So we'll figure out a good name to group like kinds of things, and then we'll figure out what level of child codes or granular codes built off of that parent's concept that we need to form to make sure we're giving the level of data we desire. Is Lisa on now?
I believe she is. Lisa, you may be on mute. Hang on, let me unmute you.
There we go.
There you are.
Welcome,
There
Lisa. Again, so we're segueing now from, we just spent the half of our call talking about the master, well, not even half, just a brief bit of the call talking about the current submissions, the master list, and our desire for data submissions. And now we're segueing to some FHIR IG updates. And we look forward to Lisa presenting.
Oh, thank you
Yes,
very
Lisa,
much.
before you go ahead, we do have questions about when the, what was the question here? It was, when do we expect the Connect-a-thon dates to be finalized, and when do folks need to pay for participation? So if you can address that as you go along, that would be wonderful.
Super. I just saw an announcement yesterday coming off from the HL7 website that the FHIR Connect-a-thon is going to be happening during the middle of the week, May 13, 14, and 15. It will be virtual, and I went and checked, and there are no amounts listed right yet as to what the registration fee would be. So that's still emerging, and we will keep you posted as soon as we know something more. But you can definitely slip your calendar to have that event during the 13th through the 15th rather than on the weekend. Okay. I think we'll go with the next slide, please. This is our roadmap, just to remind everybody where we are. The team is working right now to produce the version 0.0.4 of the IG with some improvements and reduced errors from our previous version. And we're also starting to work on use case number 2. So good progress is being made there. The Connect-a-thons, you see we haven't updated that slide yet, but we'll have to get to that. So it used to be May 16 and 17 was the next Connect-a-thon we were planning toward. And those will not be in San Antonio. It will be virtual, and it will be the 13th through the 15th. Most of our focus will be just on use case 1 at this point in time. Then when we get to Baltimore, hopefully that will be alive, but who knows, and we'll be ready to test both use case 1 and 2 by that September Connect-a-thon. Next slide. Here you go. So those are the dates, and there's the link that we have right now in terms of being able to sign up with us through Connect-a-thon. That's an opportunity to just let us know that you have interest and you want to participate. That'll let the folks within Gravity know. But then it's the HL7 event website that you really need to go to, and that link that says HL7 FHIR Connect-a-thon 24 is what you click on to be able to stay up to date with registration information from HL7. Next slide. I mentioned this already. Although we have 3 use cases in our IG, our focus for 2020 is just to produce guidance around the gathering of the screening information and the SDOH related information that would be collected during a patient encounter, as well as the information that you need to send out and receive back when doing a referral out to an outside organization in order to have some activities and interventions completed by another group. That's plenty to work on, I think, for right now, as you'll see as we get into it. But that's what we're aiming for anyway, to be able to go to ballot in September and publish before the year is out. Next slide, please. I mentioned that version 0.0.3 is available for your review and use, and the highlights here include, these are some things that we went over really last time, just the home page and the notes to reviewers where there's some specific things that we're looking for comments on, table of contents, and then you'll see some content that you should all be very familiar with. So this is where you go to access your personas and your patient stories, the key definitions of those use cases, all of our concepts from the master list that we developed for food insecurity are now built into the IG. The ones that have existing codes from nationally recognized code systems, those codes are listed there. And where there are not codes like that available yet, within the context of the Gravity IG, we've assigned temporary codes to be placeholders while we work with the code system stewards to get the needed concepts built into those code systems. We've got some good examples. We cover all the content that you've been learning about with the whole cycle of care. So it's a pretty good read, and we're making it better each cycle. Next slide. Let's talk about the work that we're doing to advance use case 2. I think this, as much as everyone's really excited about use case 1 and the ability to capture screening information digitally with coded concepts, I think the community is really excited about use case 2 because this is where we have that referral and the communication across organizations to be referring out and then hearing back as to whether or not those referrals have been completed, and also, more importantly, whether or not the activities that were intended to be done through that referral, whether those activities are being completed. And that's what we're focusing on in use case 2. And we are reaching out at this point just to let you know that we need some community input on this notion of the supporting information that might be needed and relevant when doing those referrals for services. And then what information are you dreaming about getting back if you were to have a closed loop situation, which unfortunately is really something that we don't have that much of right now. But if we were closing the loop to hear back on the status of those referrals, what information would a clinical environment want to receive back from a community-based organization to close the loop on that referral that was sent out? So I just wanted to let you know that we are in the process of pulling together a menu of data elements. So we've been working with a team who have been identifying bits and pieces of information, everything from in the area of patient demographics, different kinds of, obviously, background information that would have been collected in the clinical setting around social, like, for example, food insecurity, information already collected in the screening, or the judgment of the clinician on whether food insecurity is present or absent for this patient, diagnoses that may have been established or goals that were set, and the plan of interventions that that clinician is putting in place. We have all of that kind of information. We also are guessing at some of the other things that could be relevant, but this is where we really need input from the community because we are not the experts to know what happens for all those different framework categories when education is provided, when counseling is provided, when eligibility for a certain program is assessed. Is there information that would make your workflow easier, better, more smoothly executed on? For example, knowing what is the patient's language preference, or perhaps what would be a best time to call if someone is going to be contacted. There's things like that that I'm sure are on your wish list of information that would make your jobs easier if you were getting that right along with the alert or the cue that the referral is coming to you. As community-based organizations, that's what we'll be looking for groups that would be receiving the referral request. And then for groups that will be getting the closed loop information back, these would be folks who are in a clinical position now initiating the referral. What do you need to know that would help you understand what's going on with the patient? Do you need to know, obviously, some information about whether the referral was completed successfully, but more importantly, what kind of information about the actual activities would be helpful to get back? Did the person get enrolled in a certain program? Did they complete counseling? That kind of stuff. So the idea that we have, it's a large group of people, and we're trying to figure out how can we gather this information efficiently. We thought what we would do is send out a survey, like a SurveyMonkey survey, where we identify this set of data elements for, I'll call them that, but individual pieces of data in these different categories, and send those out and allow you to basically respond by checking the box to say, yep, these data elements are relevant in terms of receiving them with the referral, or these data elements are relevant or something that is available that we could share back that we anticipate would be helpful. And then the survey would have some open area that you can document if there are additional things that we have not thought about so far. That would be your opportunity to share some additional ideas back. So that is what we're proposing as a process to go forward. I think, let's try one more slide and see what I get onto. Otherwise, we'll take questions. This is just more information about the testing date. So let's go back and sit on that survey slide, and let's look at what kinds of questions are coming in the chat. See if I can find the chat, or if anybody else is monitoring the chat, you can read out relevant questions.
So Dr. Myers, Jim has a question regarding bringing in the community resource network, such as Healthify and Unitas or Bertha, to the referral work. I don't know if you saw that.
Yes, okay, I just found my chat button. There we are. So, I think that these are folks I thought were probably already a part of our community, and if they have been, if they've been doing other things, or it's been a while, maybe this is just an opportunity to reach out and remind them that this is the time to get back in and participate, because this is a really important input period that we definitely need stakeholders like this to come and participate.
So they were very, very involved in previous work, and I think I agree with Jim and Caroline that maybe targeted outreach regarding this particular issue would be wise. So let's.
And this is Evelyn. I do want to acknowledge that the Administration of Community Living has a grant application now open that is targeting these e-referral platforms. And encouraging them actually to more actively engage with Gravity and test the Gravity standards. So I think I do want to also, if they're not on the call, they are members, committed members of the Gravity Project. But as you all can appreciate, they're very active right now in the community addressing needs out in the field for exchanging data. So it could be, and I'll just ask, I don't think there's any of the platforms are on right now, but if you are, please speak up.
It looks like Unitas is on the call. We just got a chat.
Oh, all right, there we go. Thank you, Unitas.
And there was a question earlier from Bart Carlson regarding if anyone has a list of sources to purchase SDOH data as a service. Is anyone on the call aware of any of those things?
I think I'm confused about the question. So if that individual wants to unmute themselves and actually phrase the question, I don't know if I understand. Sarah talking, by the way.
This is Bart. So I was just wondering if there were, the project had a list of, those vendors. I know there are vendors out there that do it, and, they may sell not every single thing that we need here, but just as a way to get started, maybe 400 data elements about a person, everything from, financial, is there a need, household status, et cetera, and I'm just wondering if there's 5 or 10 of them that do it, if there's some opportunity to pull from all of those 5 or 10 to help us in putting together what the core recommendation would be to all organizations to start collecting, and if there's things that are not part of those, either to get those vendors or to, on our own, create some activity to go fill in the gaps.
This is Sarah. Should I try to take a stab at that? So I think that is certainly one approach. I feel so. What we have decided, driven by the work of Siren before us, is to really take a concept-driven approach to this, a domain-driven approach. So instead of just looking at all the, social determinants of health is a very, very broad term and it includes many, many different things.
Right.
So instead of kind of casting that wide net, really focusing on these 3 different domains initially: food and security, housing, and then transportation, and really leveraging collaborations between research knowledge, federal knowledge, community organization knowledge, clinician knowledge around that concept to integrate what we know about what needs to be said about that thing. So I think the master list, even as it stands already so early, is a really great proof of concept of that. And certainly the food and security data set as it ended up was a really robust concept of that, but it is something to consider. Thank you for that comment.
Okay.
Sarah, this is Lisa. I'd like to take a different spin on this, and I don't know if this is the intention of the question or if this is a sort of a side, a tangent. But I would like to talk a little bit about, use this question as an opportunity to talk a little bit about privacy and security and principles that the Gravity Project are going to be speaking about. Things I know Lucy Johns has brought up in the past around the very sensitive nature of SDOH data. That is a big category, but let's talk specifically about even the domains that we're looking at: food insecurity and homelessness. And I think there's another, or at least I heard something in that question that is something that I hope this community will talk about and grapple with, and that is the notion of whether or not organizations are selling people's SDOH data. And I think that as we consider our role in creating standards that make it more possible to gather and exchange SDOH information for good purposes, for care, and for improved health and life outcomes, I think we at the same time need to think about what breaks and what security and what privacy and respect considerations need to be played to individuals who are a major stakeholder in this whole system.
Excellent points, yeah.
Lisa, I think just to, oh, sorry.
I was just mentioning it for a couple of reasons. One was to, in other words, if you've got a good starting point in what the inventory is of things to pick for the standard, I'll make these numbers up, so don't anybody hold me to them. If you have one source that has currently 450 data elements available, of those 450, maybe we thought of 100, but maybe there was 5 we didn't think of, and after reviewing it, it might be good to add to our recommended list. So by philosophy on life, you find out what's available in the world, and then you take those as a potential inputs, and then review each one on a case-by-case basis, and come up with whatever the recommended list might be. And then the other one was just pure how, if some people want to get started on this or learning about these other things, where are the places that we might go outside of the committee to get that information in to really gain some more insight into what's being done in the world today.
And Bart, I definitely agree that I like the systematic approach that you're describing there, and we are starting with our own Chinese menu of data elements, but we obviously love to learn from what others are doing and want to make use of anything that's invented and figured out already. So if you have ideas on good sources for that kind of view of potentially available just a criteria or a set of data elements like that, we would definitely find that very useful. Thank you.
Okay.
And I do just want to mention the work based on Lisa's question. This is Sarah DeSilvi talking here of our working to develop our own data usage and data policies and data justice approaches. So we can find that on the Confluence. It's a work in progress that I think we will be refining over the course of the next month or so. It was initially presented about a month ago, but if, in reference to Lisa's question, if folks want to review that again, Mark and I are contacts on that work, and we presented it to the Technical Advisory Committee, and it will be reviewed by the Executive Committee again to just try to make sure it represents the principles and ethics behind the data that we're creating as we go forward. Other questions that we want to address before it looks like there's...
This is Lynette. Yes, there was a question from Greg Bloom earlier. Brought up the point, he said, my concern about this question regarding the SDOH data set about what providers need to know about people is that the question is so context dependent. It sounds like a question for application design, but not one for standardization. You or maybe Lisa want to address this?
Greg, I think that's a good question. Right now, as we were thinking about it, and we might not get every piece of data, but the standards are usually like a floor that you start with. We've been looking through the matrix that was created by the content team when we did food insecurity around the different types of referred activities. And we are wondering whether we need to be specific down to that level to be able to say if you're referring someone to receive some additional education about food insecurity, the kinds of things that would additionally help us reach out and do that referral, follow through with attempting to do that action, that intervention. The things that you would know upstream when you made the referral that would help us might be, I gave that suggestion about a good number to call and what time of day to reach out, or what language is my preferred communication. There could be other things, and what we're wondering is do we need to get specific down to that full list when it's for counseling, when it's for a consult with a dietitian, when it's for telling if you are eligible for enrollment in some kind of program. Do we want to try and be specific down to each of those levels, or are there some general things that would just be better than what we do today, that if the referral included these 10 additional pieces of information, we would be better off than we are right now, and try and take that as our next foothold? We're not sure yet, and that's what we're hoping to get back from the community.
Yeah. Can you hear me all right?
Yes, we can.
Yeah, and I get that, and I suspect that the answer is no. I suspect that the answer is these circumstances, the services and the contexts are so vastly diverse that if you are trying to standardize the content, as in the specific kinds of information that people may need from one to another, I'd be glad to be proven wrong, but I suspect it's not really possible. That's different from specifying the method by which the data is shared. Right? There's an important distinction between trying to establish syntactic interoperability, meaning data from different systems can be correlated through the same ways, versus semantic interoperability, meaning everybody is describing the same things to refer to the same concepts. And when we're dealing with the entire range of potential experiences related to food or housing, semantic interoperability seems to me to be a locally possible but globally impossible goal. Whereas syntactic interoperability, meaning different systems can share data, whether or not that data means the same thing, that seems globally possible.
Well, this will be an interesting experiment that we are playing out together. And, you know, I would ask, what are we sharing today? If you think about, you know, because these organizations are making referrals and they're sending information downstream about patients that they know of that would benefit from a reach out for the potential to have some services provided. And we can look at what information is being provided today. And maybe we wouldn't get all of the pieces that, as you said, would make it completely specified for every different context. But there might be a subset of elements that are typically needed by many of these organizations. And if you could imagine it being possible to have that be specified more easily up front, because that's what standards really do for us, is they eliminate a lot of the specific negotiation that has to happen every time some new information exchange needs to happen. And if we had the ability to at least even offer to a community-based organization that comes online in a community to say, hi, I'm here to help do blah, 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 please know about me, we could say, we want to help you be successful. If someone is giving a referral to you, we've identified these 50 different data elements that are largely available in clinical systems. Which of these would be helpful to you in your referral? And if they could at least get those ones that are helpful, and maybe they don't get everything that they need, and some of it might have to be supplied after they make contact with the patient, I would say, although it's not going to be perfect, I'm not going to argue that we're going to standardize every single thing. I'm just saying that if the referral could be set up that in that kind of a more standardized way, not that everybody needs the same data, but if the data elements that they needed could be picked right off that list and make that an easy thing to do, it does feel like that would be a step in a better direction than what we have today.
Yeah, I suspect otherwise. I'll only make one last point on this, which is, you know, much to somebody's point about the AIRS taxonomy, there are existing standards that are already in use, and so I agree with regards to developing standards to make people's lives easier, but there's a difference in strategy from trying to build a standard from scratch to trying to enable different realms with different standards to interoperate at some level. And rather than trying to start from scratch, I suspect there may be more practical success to come from developing the means to facilitate exchange of data among different systems with different standards, and by pointing to those standards and by demonstrating that those standards can work together, rather than by trying to build something new that inadvertently or otherwise ends up competing with them and recreating the problem that we came here to solve.
Yeah, good point. And I would like, I hope that the folks from the AIRS taxonomy will come and participate, because FHIR is a structure. It can accept and carry many different kinds of concepts. Like you said, the syntactic exchange of the information is what FHIR is saying. The additional meat on the bones is to talk about, well, what codes are we going to share, and what information is conveyed in those codes is an extra layer on top of that. But we certainly need to, the FHIR IGs are trying to provide that kind of guidance so that everyone has equal and open access to being able to communicate the things that they need to share and say. So I think that's why we're trying to explore down this path, and with a very large community that all wants to be able to do that basic capability.
I think it's also true that one of the reasons that we have this collective is to make sure that as we build in any kind of standard that we glean and integrate the knowledge of the community. So this is the great things regarding these public calls and regarding our technical advisory committees, right? Is really trying to ensure that we do this work wisely and correctly. Are there, Lisa, thank you so much. Are there?
No problem. I think the last slide is just a reminder about the testing, and that's, you know, just like we benefit so much from the feedback that you all provide during these discussions, we really benefit from folks who are willing to jump in and attempt to implement and to come forward to, you know, find where the glitches are, where there are even opportunities, things that have been invented already, ways to do things. We definitely need the community to stay with us for those that are in a position to try to implement things and help us learn at the implementation level, not just the discussion level. So these opportunities, which now are virtual events, and we think will make them even more accessible and easier and less expensive for people to participate, we encourage you to get these on your calendars and plan on being a part of the technical discussions that happen in these forums. Next slide. Our next steps, really focusing on use case 2, and really excited about the dialogue shifting over to talk about the referrals that happen as a part of the care planning from a clinical environment. We aim to have a new version out by around April 20th, definitely available before we have that May Connect-a-thon. So if you feel that you would be able to participate, there are several roles from a clinical system to the systems that are involved with screening for the patients, and as well as secondary use systems that are asking for the information from the clinical visit to be shared so that they can gather and aggregate and provide learning health system capabilities, quality measurement, population health, secondary kind of uses of this natural byproduct data from the clinical care. We have invented a role for folks that we don't want anybody to just be observers. We want everybody to be engaged and playing a role in this hands-on experience. And so if you're interested and curious, there would be a role that you could play to just be a patient, be yourself, and be a part of the testing so that you can see what it would be like to receive one of these screening instruments on your phone or laptop, and be able to supply the answers and feed that into the example use cases we'll be working on. There's the links for how to sign up. Let us know about your interest. That's gravity level sign up. Just make yourself known within the community. And then we have been doing some prep sessions with folks to bring them closer to the IG material, understanding the different transactions and how this is envisioned to work. They're all recorded, so it's okay that you've missed some of them. You can go to that page and catch up with us because you're all home with nothing better to do with your time than stay on your computer. And so you can watch those recordings and get caught up, and we do have 2 more sessions planned for April 15th and April 29th, and we hope that will give everybody a level of comfort to come and be ready to contribute. Next slide. That might be it for me. Yep. Yes, Lucy.
Yes. I guess I'm not familiar with consumers participating in Connect-a-thons. Could you go back to that invitation and elaborate a little bit?
Sure. We have a role in use case 1 where the demonstration is to show how it is that a clinical system would request to screen a list of patients for, in this case, what we're focused on is food insecurity. So we've taken the questionnaire questions that were gathered by the Gravity community that are relevant for screening people for food insecurity, and we've shown technical systems how to represent those questionnaires as FHIR, those screening instruments as FHIR questionnaire. And that resource can be shared with an app that can be in the hand or on the desktop of a user. a patient. So in the demonstration, somebody needs to answer the question. You know, have you in the last 12 months not been able to get the food that you need? Sometimes, often, never, you know. You have to answer the screening questions just like they would be given to patients when this system is in production. So we made that role as a role that people who aren't bringing the heavier duty systems like standing in for an EHR or the system that a company is creating to manage that kind of delivery of mobile apps to consumers, or a system that is like a public health or a population health or a quality measurement kind of system that's getting the data and doing some analytics on it. You might not be an implementer or a company that has access to developing that kind of technology, but everyone in this Gravity community is able to act as a patient. So we just made that spot available to make it possible for more people to come, get engaged, feel what it's like to be a part of a Connect-a-thon experience, and have some technology in your hand so you could play a role.
Thank you. So that is the first link on this slide. And would consumers be expected to attend prep sessions, or are prep sessions techies?
The prep sessions are probably a little bit technical, but I would encourage people to be exposed to them. Just like, you know, learning how to dance. You can't just really learn that from sitting on the sidelines. You need to get out on the dance floor and give it a try. So going to the prep sessions really help you understand what we're attempting to do. Even if the role that you play is just, you know, one spot in one scene, there's actually two scenes where this kind of comes into action. But I think that attending the prep sessions helps you develop vocabulary and helps you get comfortable with how we've dissected the use cases into different, we call them scenes, and where your role would fit in. And plus you learn more about the other roles that are envisioned to be played. So I'd still encourage it. And I would encourage you, when you do that sign-up link, it is an option for you to say, I'm brave enough to give it a try, and I want to come and just try as a patient.
Just to be devil's advocate, ultimately, these apps will need to relate to people who've never attended a prep session. So maybe it would actually be better for someone who wants to play consumer not to attend a prep session, so that they're being reached cold, and they can respond spontaneously as other people might, and thereby reveal what might have to be fixed or said more clearly or
Difficult.
whatever.
Yep. That's a very good point. I agree with that. And who would disagree with less work, right? Now you don't even have to go to the prep sessions. Just sign up and come.
Thank you, Lisa.
So this is Lynette. We had a question from Art Davidson earlier asking how the community-based organization is represented and their perspectives. For example, a limited technology capacity. How are these considered at the Connect-a-thons?
Well, the ability to receive a referral via FHIR is a technology that that is envisioned in this FHIR IG. That's the scope of the work that we're doing. That doesn't mean that that's the only possibility. There are companies that are engaged with using other technologies than FHIR to be able to make things like this possible. But our scope as an accelerator of teaching people how to use FHIR would be to introduce organizations to the possibility of having a FHIR client or server kind of added into their system environment. It's definitely challenging. My company, MaxMD, is a direct trust HISP, and you know we are also looking at using existing technologies that make things easier, like direct, for organizations that are not technology enabled. And for them, it might be better to be able to receive something that's akin to a secure email with this referral information in it. But that isn't the focus of the FHIR Connect-a-thon work. So I would say if you're a community-based organization and you are in that position where you could say it doesn't make sense for us. We don't have FHIR-based technology to even make use of this guidance. I would say sharing that perspective is important to be registered so that the larger Gravity community can be facing this need to figure out how will we connect everyone that we want to connect when FHIR might not be the only answer that we need.
Thanks, Lisa. And Sarah, I'm going to ask you to talk very quickly because I'm going to ask one more question while we have everyone. Jane Persig asked earlier, are we assuming that if the data is available, it should be asked per patient privacy issue, whether HIPAA is covering it or not? I hope I interpreted that question correctly. And Jane, if you want to unmute and add to this, feel free.
Sarah, well, I don't know if you're on mute or if you're just thinking it through. I would like to say consent is a very important aspect of all of this, and we have consent spots considered in and before each information exchange is to happen. So I'm very sensitive to this issue of whether people are consenting for information to be shared, and that information should only be shared when there is consent for it. And HIPAA doesn't always cover, well, HIPAA always covers, obviously, always covers covered entities, the clinical systems that are a part of the clinical environment. But when it comes to community-based organizations sharing information back into clinical organizations, I would think that patient consent needs to be a very important consideration about that.
We do, again, I think this is Sarah. I really feel like so many of the conversations we've had today are pointing us back to trying to make sure that the data principles and data justice elements that we've presented to the community get a more lively look, because there are elements of consent and permission in there as well. And I definitely want to make sure that we have develop a document that reflects our needs. I want to see if these last minutes, the homework is clear. I want to see if we can actually open up the conversation to actually reflect. So do we have time just to briefly discuss Matt's concept about data and COVID? We really are trying to focus as many things as we can on the current health crisis. And it looks like Megan might have responded to him. So looks like Matt was asking a question regarding, let me see. I can find it in here. So regarding transmissibility and social risk, he's like, for example, are there clinical codes for something related to patient is able to shelter in place or patients able to socially distance, which might be difficult in a homeless shelter? And then, so Matt, do you want to briefly unmute and close out the second call of the day with some thoughts regarding your thoughts regarding social data and COVID, just so we can end there maybe?
Sure. So some cities like New York are developing specific locations for patients that have been diagnosed with COVID to be referred to for quarantine. And then others on a more basic level, just the concept of that they're in an environment where they can social distance, I would imagine would be a very important concept. So.
Any thoughts on that? So we have both the those are the kind of the housing, and actually this actually kind of reminds me of what you and Lucy were talking about at the end of, I think, one of our more recent calls as well, regarding how economies and neighborhoods influence the ability to follow the many CDC directives we have. And certainly you think about homelessness playing into that as well. Any other thoughts? Megan, you responded. Do you want to pipe in?
Well, I don't know that anything specific to add. I was just volunteering because he'd asked if there were any epidemiologists with the group. And I was trained at the London School of Hygiene and Tropical Medicine in epi and demography. So I'm far less knowledgeable on the clinical coding side. But happy to talk about kind of the social determinant and interactions. We're having similar conversations. I'm based on the West Coast, and Portland, LA, and King County and Seattle are also struggling with those same problems of ensuring adequate spacing, and how do you make sure that you're asking folks the correct questions, particularly those who are experiencing food insecurity or homelessness.
This is Lisa. I don't know how to answer the question of how do you know if you're asking the right questions, but I do feel excited about the fact that we've established a framework to rapidly identify a set of questions and what the possible answers might be, and then demonstrate our whole pathway of bringing those kinds of questions and answers as screeners into a clinical care setting. So we have the potential, if there were 2 or 3 questions that you guys invented with the answers, we could produce temporary codes and demonstrate at our May Connect-a-thon how a screener questionnaire asking those questions could be brought right into the clinical care setting, just like we're doing with food insecurity. That's the one nice thing about standards. Like Greg said, it sets up a framework. It doesn't have to be specific to the content. Once you know how to share the information as a framework, then you can put other concepts into it, and you already know what to do. And so we could swap in some questions and answers that are relevant for the examples that were in the chat here that might be relevant for the COVID-19 situation, and then just play that scenario out.
I also,
Go ahead.
I just want to recognize that I feel like we don't ever have enough time to do this question justice, right, on these public calls, because there's so much other data we're covering. So, and it's true even about the HMIS HIT group that we have. We're looking at the Homeless Management Information System data. And so it seems pressing enough that maybe what we should do is try to hold a designated meeting to try to look at this question specifically. And I'm willing to field emails from folks who want to do that specifically, not smushed into another group, but a gravity focus just on HIT and COVID and seeing what we can come up with. So if folks want to, the homework is data submissions, reviewing data justice principles, right? If you and then you can, the contacts are Mark Savage and myself here. And then review that master data set that we put up onto the Confluence yesterday, submit your own data concepts. And then if you want to have a designated meeting regarding this question, I actually feel like we can't really push it off anymore and shove it into other agendas. So write me, Sarah DeSilvi, and then we can try to figure out a way forward. Oh, and then Evelyn has something she wants to say as well.
Evelyn, you're on mute.
Thank you. It muted me on purpose. Sorry, and I just want to piggyback on what Sarah said. I think this is a great opportunity. We got feedback today from our executive committee that we have an opportunity to truly tie Gravity SDOH efforts with COVID-19. And so they encourage us actually to stand up a public site, have some sort of web page where we can have resources and really point people to. So if we can meet with folks that are interested in this topic and want to contribute to that, please reach out to us, our email, gravityproject@emiadvisors.net, and we can convene a smaller group. Thank you.
Maybe you could decide to do that and email all of us instead of asking each one of us to email all of you separately.
That sounds lovely. Okay.
That's good too. Great. We'll send it up and invite you all. Thank you.
You're so good.
Thank you.
This is Lynette. Just a quickie thing before we let you all go, because I realize we've kept you over and I apologize. If you are not currently receiving emails from Gravity Project at emiadvisors.net, please go to the Confluence and join the project. That's the only way you can get added to the listserv, or by emailing gravityproject@emiadvisors.net and asking to be added manually. So if you would like to attend the meeting that we're discussing, please do go ahead and join the project. And I think with that, we will go ahead and adjourn. You all know where to find us. It's an open door communication. We truly appreciate you all. Thank you so much for this work and for all these thoughts today. And we will talk to you all in 2 weeks.
How long before the recording is available?
The recording typically takes about 2 business days because we have to convert it before it's
Thank you.
posted.
Okay,
No problem.
thanks.
All right. Okay, everyone, thank you so much.
Thank you.
Thank you.
Thank you, bye.